My name is Tendani Gaolathe, as mentioned. Currently a lecturer at the University of Botswana School of Medicine and also a researcher at the Botswana Harvard AIDS Institute. I got the bad slot, the first one. Anyway, what brings us here today? Controversies for ART use in women of childbearing potential and pregnancy. I must admit, with the current controversy, mainly around dolutegravir in pregnant women, for us as a country, it was not necessarily from a researcher's perspective, but maybe by default, it brought forth a lot of the discussions around DTG. We do appreciate that DTG is one of those drugs in the history of ART development that really has been on the radar. With advent of national programs and the drug choices that we've had before, I'm not quite sure that we really thought much about it, but at that time, it was a question of life and death and what we need to do. Going back medical records, having seen prescriptions on D40, DDI, sometimes I cringe and I wonder how we actually prescribed those drugs. Anyway, this will mainly focus on the Botswana context of the famous Tsepamo study by Roger Shapiro and Rebecca Zesch, as we know from the Harvard School of Public Health. And these are no new slides by any means. But Tsepamo, the study was a birth surveillance study in Botswana, which was designed to evaluate the risk of neural tube defects with preconception for efavirenz. At that time, Botswana actually was one of the last countries to offer efavirenz to pregnant women. We were always struggling between nevirapine and lopinavir in the first trimester. So at that time, they were looking at the denominator with control groups, and they were able to distinguish between ARV regimens for the uninfected, infected preconception, and ART started during pregnancy. And this is what broke the camel's back a year or so ago at IAS. The 4 neural tube defect cases in the 426 exposures on dolutegravir preconception. This compared to neural tube defects in our setting was at 14 per 11,200, was almost 10 times more in HIV infected on dolutegravir versus non-infected. At this time, we were not sure if all this could be attributed to DTG, but it did get us thinking about a lot of issues. These really were the prior findings for Tsepamo. At the time, they were looking at efavirenz as a comparator for the drug choices that we were offering pregnant women. And they looked at any adverse birth outcome and severe birth outcomes. But we do appreciate that for the lopinavir-based regimen, we did have higher rates of any adverse birth outcomes followed by the ZDV-based regimen. I'm not quite sure that we actually paid attention, or the world paid attention, to suggest anything else for women of childbearing potential or pregnant women, but that is the data as it is. I think we started digesting it more when the DTG issue came up. And here at CROI 2017, in terms of the birth outcomes pitted against DTG, we did get some sort of reassurance that maybe DTG would be the way to go. At this time, Botswana had already moved to DTG June 2016 at the start of the Treat All program. And here it was just comparing neonatal deaths against the previous old regimen that we used to use. And also with that, the PI-based came higher compared to the comparator efavirenz. But then again, with DTG, we did get some semblance of comfort that, well, with DTG, we may have that chance. Stillbirths, the ZDV, top of the list, followed by the PIs. And again, compared to DTG, we thought, well, this may be the way to go. Since this broke out, there have been further look into outcomes of women who were on DTG, more so that DTG was taking the world by storm and was the next possible drug. And from the Glasgow conference, they did release 3 major papers. The Central and Eastern European network groups that conducted a survey in 20 countries, they did admit, though, that they had complete data from 6 of those countries. Of the 415 women who took dolutegravir, 24 preconception. They really did not mention anything about NTD outcomes with DTG, but for the fact that maybe nothing was mentioned, it was sort of assumed that none was found. I stand to be corrected. The Frankfurt cohort also that reported outcomes of mothers and infants exposed to integrase inhibitors during pregnancy. 274 between 2008 and 2018, of whom 19% were exposed. Of the exposures, no neural tube defects were observed. And the Canadian HIV Perinatal Surveillance Program also did have a look. Of the 2591 infants, of which born to mothers receiving therapy, 2 neural tube defects were reported, but neither of those were from mothers who were taking DTG preconception. But of note, the study did find a 3-fold higher rate of congenital abnormalities in infants exposed to elvitegravir during first trimester, at 10.7% in the 28 infants. The Brazilians, I think they were in the forefront with Botswana as the first adapters for DTG for their national programs. And just after the alert, they also actively evaluated the occurrence of any signal of DTG exposure. It was mainly retrospective from January 2017 to May 2018. At that time, 363 women exposed during early pregnancies had been identified in the national system. The study continues, the retrospective continues, and we do expect results by April 2019. So this is just in summary. Their cases are DTG-based versus efavirenz at a ratio of 1 to 3. Nothing to report to date. So what did Botswana do? We did not take this lightly. Botswana is one of those countries in Africa that has a high ANC attendance rate, with over 95% of our pregnant women accessing ANC services. So through the Tsepamo study, we know that they were really surveying more than 45% of all deliveries. And with the Ministry of Health and Wellness in Botswana, with support of CDC, we decided to complement the study for greater reach. So really, from the CDC MoH perspective, the surveillance was for all live births and stillbirths delivered at 24 health facilities in Botswana, to analyze the data and to see if the safety signal was real. And in many ways, this set up the beginning of our national surveillance program. Sorry, this should have come first. So this is what it looks like. For the Tsepamo study, the original Tsepamo study, it was at 8 sites and had a coverage of 45% of all births in Botswana. And with the signal, Since the signal, the study was funded to extend the study and included 10 more sites at 27%. So really now they were looking at 72% of all births in Botswana. They are due for completion by end of March, and I won't be reporting anything on their behalf. But for the Ministry of Health complement, supported through CDC, we added 22 more sites, which added 20%. So really for the surveillance, it will cover 92% of all deliveries in Botswana. Just to show the geographical spread, most of the facilities, of course, are in the east. Botswana is very sparse. The west is more desert. And with the expected deliveries we have there, about 8,965, and this will, with DTG will be 19% of all the deliveries. So our surveillance activities up to date, we are in the last 4 weeks of our data collection, and all sites have been activated and been collecting data. We do have ongoing quality assurance visits, and I think this coming week we will be having our external auditors from CDC. What have we found to date? Not necessarily official, but this is what we have from their section of the Ministry of Health and CDC input. To date, 1,668 deliveries recorded with 3 possible neural tube defects. One in a hospital in the central aspect of the country. The mother was HIV negative, and one the mother was positive on DTG and Truvada. We're still trying to, this was reported early January, we're still trying to establish if it was preconception or not. And there was one in the Joanning Mine Hospital. The mother was positive on A-tripler. So what does that mean for us? With the signal that we had at that time, we're looking at a 0.94%. And with the one additional signal case we've had, we're down at 0.6%. But of course, we don't know what the other complement will show. Even though I suspect if we had something, I think the bells would have long gone off. Final thoughts. I think this I just rushed through, maybe from a research perspective, or maybe from a programmatic perspective, what this signal brought to us. First, for a lot of our countries, I don't think we really had active surveillance programs. So this really has been the setup for our active surveillance programs. For the policymakers, this was a very tough decision. And we did not get enough guidance, or a lot of countries were wishy-washy whether to offer DTG or not. Even though the final position of Botswana was for pro-choice to offer DTG in women if we could also secure family planning for them. Actually, what does this mean? From a women's health perspective also, family planning and reproductive health in the context of HIV is one area that we have neglected. With most of our programs, especially in the African setting, with more than 60% of women actually on ratios on ART, more than 60%. We also know that in our setting, more than 50% of women who got pregnant also, it was unplanned. So the need to address this unmet need for family planning. I think this also got us thinking about the older regimen that we have been using for ART. It may not have been neural tube defects, but, you know, small for gestational age, neonatal deaths and all that, that we may also need to go back and really pay attention to that. I think most importantly at this difficult time was the support from the civil society and activists and women for choice in terms of what is it that they think is good for them, what is it that they will accept, how can we help to make ART provision safer for women in the reproductive age group? And lastly, we also know, at least in our setting, in terms of resistance patterns, our hope for DTG in a lot of settings that did not even use viral load monitoring in the past. But more importantly so, the transition to generics. And with the proven efficacy, tolerability, and cost effectiveness, the possibility of achieving the targets that were set for treat all. We truly hope that the signal fades, and we are still anxiously awaiting to hear from other researchers in all countries and settings what it means. But in the meantime, this has really given the global community an opportunity to highlight the all-cause mortality in birth outcomes and advocate for and better fund regimen and effective contraceptive methods, and also improving pharmacovigilance for all regimen. I think that is the last slide. And just to acknowledge our partners, Minister of Health, CDC, Dr. Raisima, who's the PI for the Botswana, and Roger and Rebecca Zesh for Tsepamo, Dr. Avalos for the Karina Center, and the BEAT team. Thank you.
Thank you very much, Tendani. We do have time for questions just of clarification, so not your own viewpoint, professional or personal, on this topic, but more if you have questions. Yes, go ahead, and please introduce yourself.
I'm Judy Levis from Baylor College of Medicine in Houston, and I have a question about folate. I know that some of our Baylor researchers have some preliminary information suggesting that dolutegravir and folate may compete for one another. And among all the studies that you mentioned, I believe Botswana is the only one where there is not folate supplementation in food, whereas like Canada, yes, Brazil probably. And I'm wondering if you can comment on folate and whether women who are being put on dolutegravir are being advised to or should be advised to take folate.
Yes, we have looked at that in country. You know, Botswana, as we know, is one of the countries that is highly dependent on South Africa for food. And South Africa does have a policy. They do fortify their grains. And really, that's where most of our imports come in. From a program perspective, the issue of folate has been discussed and is on the table. And I don't have much to say at that, but it is a recommendation. Actually, it is something that should have been implemented, but at times we have issues of procurement and laxity in some of the monitoring aspects of our programs. But that is noted. How it competes with DTG, we don't know, if we haven't seen much from those countries who actually supplement from folate and their outcomes for DTG. But also for the 4 cases in our country, we have been looking for sponsorship to really have an in-depth analysis at whatever peculiarities there may have been, because we don't seem to have any common thread.
Margaret?
Thank you. That was a really clear presentation. Can I just ask, since the signal was raised, what percentage of women have chosen dolutegravir?
Really, since the signal has been raised, we have women have been offered the choice. You will realize that in our setting, most women will come after the first trimester anyway. Yeah. Planning is not in our domain. But at initiation for naive patients, they are given those possibilities, looking at their reproductive potential, offered family planning and DTG, and the other option of going on A-tripler. We have really had, maybe in my experience, less than 2 have ever received and refused DTG. Because at that time, I guess for most women, they were not thinking of getting pregnant. They've heard great things about resistance and all that, very minimal. And it doesn't seem there is a concern around that.
Thank you.
And one more? Yeah.
Thank you, Dr. Tendani.
Just introduce yourself.
Reina Patel from University of Washington. I was curious, it's great to see the programmatic surveillance work that you're doing as a way future for many other programs in resource-limited settings. Could you comment a little more on your procedures for the surveillance? Did you, similar to the Tsepamo study, did you do photographs? Did you consult with a neonatologist or a geneticist? How did you implement some of the research rigor in your programmatic work?
Well, the programmatic aspect really mirrors the Tsepamo study. In that, the Tsepamo study was not asking for anything that should not be done, you know, at ANC or PNC or in the maternity ward post-delivery. So really, this was just looking at the registers as they've been designed. They've always been designed for testing, for regimen use, and in the maternity wards, the outcomes documentation. So for us, it was more really emphasizing on the documentation and the reporting aspect of all these outcomes. With the funding, though, it helped really for the data assistance, you know, for the quality assurance aspect of the whole effect. Yeah.
So one more question at the back.
But they were consented, of course, and even for taking pictures.
Go ahead. Number one.
Hi, thank you for that great presentation. I was curious
Your name, please.
Tanvir Bell from the Food and Drug Administration. How rigorous is the screening for diabetes in Botswana at the different sites, just to see if there's any other reasons why someone may have more birth defect problems?
Well, we do follow the WHO standard approach in ANC for all the screenings that you would need to have for pregnant women. Hepatitis, STIs, diabetes, and so HIV, and basic hematology. So we do just follow the standard regimen. Yeah.
So it'll be, okay, one more question.
Yes, Justyna Kowalska from Warsaw, and it's just being called to a table because the data you showed from Central Eastern Europe Network Group, I put them together, and just to explain that we predefined that we will not report on dolutegravir outcomes because we believe we do not have access to the quality of the data. So some of the sensors would not be able to go back to pediatricians and ask for that. So it would be overestimating or underestimating. Also, I'm a chief investigator at the Dolomite study, which would try to look at this problem more across Europe and also including Canada. And the mastermind behind the program is Anton Pozniak. And we do believe that it is very important that you have a quality of data that are sufficient to actually be able to confirm the outcome in neonatal outcome, because very often we are lacking that. So just to clarify, thank you.
Thank you. I was looking for that answer because there was no comment on the paper. Now that she's clarified it, I think if there's no more questions.
Well, Tendani, I just want to take a co-chair's prerogative here just to ask you, there's a lot of focus now on contraceptive choices in Africa, and we're waiting for the results of the ECHO trial a little bit later in the spring, maybe June. I'm just wondering, you mentioned, but what is available in Botswana right now in terms of contraceptive choices for women?
Well, in Botswana, we do have DEPO. We do have a program on implantables, of course, your usual condom. But we also know we do have our reproductive health specialists working on our new guidelines. We also know that efavirenz has failed us with the DEPO, but we haven't seen much with the DTG. I don't know if Dr. Avalos wants to comment. Maybe Kate? Yes.
Mm-hmm.
Yeah.
We don't always Thank you. Sorry. We really have a supply chain issue. So we have everything in the guidelines, but whether or not it's available is questionable. So again, we have lots of really good intentions, but maybe it doesn't always trickle down. I just quickly also wanted to say that I just noticed a typo on one of the slides, and I think it's important. It's the current, as far as we know from Botswana Harvard Partnership, the current NTD is actually 0.6, not 0.06.
Yeah, 0.6.
Because I saw a lot of people
yeah.
snapping,
Yeah.
so just know that the signal continues to fade, and right now it's 0.6.
Okay.
Thanks.
Great. Thank you for the clarification. And thank you so much, Tendani. That was excellent. Let's
Thank-
give her an applause.